Okay. Yeah. So it's great to present here today. I'm an academic pharmacist actually from Bangladesh. So I'm doing my PhD with the Department of General Practice, Monash University, with the GP pharmacy collaborative stream of AMS. Okay. So before starting, I want to highlight some part of my work and some of the findings from different work stream, particularly an evidence of GP-pharmacist collaborative AMS approach and the uptake of AMS strategies by Australian GPs and the attitudes of Australian GPs to working with pharmacists in AMS space. So actually, because of the pharmacist positions in the community, they have a scope to work collaboratively with GPs and providing a lot of AMS interventions on to the patients as well as on the prescriptions to minimize the allergies, the side effects, the dose regimens, a lot of opportunities the community pharmacists have. But in reality, it's a really big challenging to develop this GP pharmacist collaborative AMS implementation model. So to establish this collaboration, actually, we need to identify a lot of evidence practice gaps, and particularly in the evidence of effective interventions that supports GP pharmacist collaboration and how GP and community pharmacists are responding to national AMR strategies and AMS strategies, and to what extent they are uptaking the evidence-based AMS strategies while they're prescribing and dispensing antibiotics, the mechanism of how we can enhance their engagement in AMS space, and how to optimize the use of AMS resources that have been developing as part of national AMR strategies. So identifying these evidence gaps and formalizing the role of pharmacists is incredibly important to progress AMS in community. So therefore, that's actually my PhD is dealing with, just to meet some of the evidence gap in Australian community context. So we started with a systematic review with the research questions whether and what pharmacist-involved interventions are effective to improve antibiotic prescribing by GPs. So we published the protocol in BMJ Open. And just briefly presenting the findings of this systematic review, and a meta-analysis based on 15 studies actually showed that pharmacist-involved interventions have associations with the reductions of antibiotic prescriptions and improvement of guideline adherence. An absolute effect in terms of reduction is 7%, and the guideline adherence improvement is 12%. And it shows the team-based AMS strategies, GP pharmacist collaborative or GP pharmacist and infectious disease specialist, the team-based approach was really effective. So what do those interventions look like, actually? So this is GP pharmacist collaborative group meetings and the pharmacist lead academic detailing and educational training, that is in presentation and workshop or didactic lecture, and the guideline development and dissemination by GP pharmacists. Collaboration in terms of developing the local guidelines of DART-tier or UTI-specific guidelines, and the audit and feedback that we discussed before, and the delayed prescribing strategy as well. So, and particularly some other kind of interventions that have a scope of GP and pharmacists working together, and particularly in the point of care test, or the collaborative practice agreement and prescription review. But the post-prescription reviews, that's really happening in hospital settings, but that's really hard to make in community the way we want. So now the question is, and we published this systematic review with Journal of Antimicrobial Chemotherapy this year. And So now the question is, how much of these effective interventions actually undertaken by Australian GPs, and what are their current awareness regarding AMS and use of AMS strategies, and particularly the attitude towards working with pharmacists to undertaking AMS. And we developed an AMS survey tool with 34 items and 5 constructs, particularly the awareness and the use of AMS strategies, attitudes of collaboration, as well as attitudes towards future improvement strategies. So those are different constructs of this survey. And we deployed this survey around 3,000 GPs across Australia. And we got 420 GPs response to this survey, and actually 386 responses were eligible for complete analysis. So what's the result? Actually, in terms of the awareness of AMS, the GPs, nearly 60 to 70% GPs, those respondent GPs actually familiar with AMS, and they believe that AMS can reduce use of antimicrobials and reducing the healthcare cost. But it's still 50% respondent believe that the individual effort has minimal impact to bring reduce antimicrobial resistance. So that's, we need to work it out. And in terms of logistic regression, we found the 2 significant predictors. The GPs who completed NPS antimicrobial courses have more awareness of AMS, and the female GPs as well. So in terms of the use of AMS strategies while they're prescribing antibiotics, so the number of strategies in like the audit and feedback and the using peer prescribing reports, use of point of care testing or sharing patient information leaflets, the adoption is very, very poor. It's like 10 to 20%. And but the 3 AMS strategies that are frequently used by GPs according to the response is like using national antimicrobial guidelines and use of delayed prescribing strategies, and they're educating patients in terms of regarding unintended consequences of antimicrobial use. So that's nearly 70 to 84%. So that's quite good. And again, the logistic regression also showed that the GPs who completed NPS antimicrobial courses have more adoptions of AMS strategies. But in terms of the use of strategies, that actually reflected the lack of AMS resources for GPs, and that actually contributed, reflected the poor uptake of AMS strategies. So we need to find out why they are not using, and how we can facilitate this kind of strategies in future. So in terms of GP-pharmacist collaboration, what the attitudes they belong to, so in terms of regular group meetings, the respondent GPs were receptive to allow pharmacists in the general practice to discuss antimicrobial pharmacotherapy. And the GP, interestingly, more than 60% GPs, they're happy to take recommendations on dose or formulation of antimicrobials prescribed. But nearly 50% GP, they are receptive to pharmacists providing advice on the choice of antibiotic. So, and overall, in terms of use of my health records or exchange of electronic prescriptions between GP and pharmacy, then the mode of response was really neutral. And the pharmacist co-locations in general practice to optimize antimicrobial therapy, the nearly 40% GP, they're happy to, in favor of co-located pharmacists to improve AMS. And overall, nearly 60% GP, they believe that improving AMS in the community will need a policy that better supports the GP-pharmacist collaboration. But overall, when I combined all the responses in this construct, actually 48% GP, they are in favor of GP-pharmacist collaboration compared to 23% disagreement. But a lot of issues that come out with the open-ended questions in the survey when they describe the barriers to facilitate AMS during their practice. So I'm just highlighting in terms of the GP pharmacist collaboration, what are the barriers they listed and responded to the survey. So GPs are really concerned about pharmacists' knowledge and abilities, and the ignorance of patients' conditions, and the scope of communication and conflict of interest. So some of the points they said, like, I'm not sure that community pharmacists are the best person to educate me on AMS. And some doctors find it offensive, depending on the approach. And then another GP responded, they're happy to take advice, but not happy to be constrained by someone who doesn't know the patient and their situations at all. As well as I do believe it needs to be collaborative and acknowledge my expertise and knowledge of patients, family or background circumstances. And even GPs might not be receptive to pharmacists interfering and advising them after their consent. So, and I'm unwilling to have the pharmacist telling me what to do. So some of the professional issues is here, and as well as one of the perceptions that is highlighting that the role of pharmacist is truly dispensing, not beyond that. So one of the GP responded, pharmacists are so often give not only advice that is wrong, but even change the generics, and they have at times not enough knowledge of patient's health. I disagree role of pharmacists for consultation, and they are trained and their profession is proper dispensation of drug, prescribed by a trained medical practitioner. And the pharmacists have a conflict of interest. They get paid for prescribing something or may have more profit from OTC co-ops or cold preparation. And in terms of from a patient perspective, they believe that not all patients want the pharmacist to know their diagnosis. So that's another, some of the barriers listed as barriers to develop GP pharmacist collaboration in future. And so in terms of the attitudes towards future AMS strategies, what they want, they are highly receptive to participate in future AMS training programs, and the policy that limits the prescribing of selected antimicrobials, and introductions of the standard guidelines, how to conduct AMS and what to start, how to start. So that kind of guidelines really they're happy to get, and particularly nearly 90% GPs, they say they responded and they supported that integration of electronic therapeutic guidelines that is integrated to the prescribing software. But in terms of the professional organizations to define their role, nearly 40% GP agreed to redefine their roles. And nearly half of the GP actually, they are happy involving specialist physicians and pharmacists, providing individualized antimicrobial prescribing feedback to improve antibiotic prescribing. So, overall, the GP GPs are aware about AMS, but currently there are poor adoptions of AMS strategies by GPs. But we need to seek the reasons of poor adoptions of AMS in general practice. And but on the pharmacy, community pharmacy perspective, we almost finished the nationwide surveys on AMS, but we got 615 response, but we're just currently analyzing data, and then we'll be able to compare the similarities and differences of different constructs of AMS strategies, and to get some really good insight to think about what are the strategies might be feasible to conduct and in this context, and in particular in the contextual feasibility and acceptability of these interventions through paired interviews. So I'm really thinking to do a paired interviews with a single GP and single pharmacist, and then placing those evidence-based AMS strategies, and then what do they think about these AMS strategies? Is it implementable by GP pharmacist collaboration, and what are the related barriers and facilitators to do that? So that's the two different projects outcome of my projects, and I'm halfway through my PhD. So I want to just summarize little things. So really we need some evidence base in terms of effectiveness and feasibility of different AMS strategies in Australian primary care context. And in terms of education and training, actually, we need to engage those AMS pharmacists or ID physicians to train and equip GP and community pharmacists to play their roles, and where to start and how to start, and to developing some audit tools and what we discussed today. And maybe like pharmacotherapy audit meetings, that happens in different contexts, but in Australian context, it's really a long way to go. And particularly without GP pharmacy practice agreement, it's really hard for community pharmacists to conduct post-prescription review, and particularly the environment of community pharmacy, time for settings, and the use of point of care testing as well. So that is not accessible and available in the community pharmacy as well. So, and some kind of policy limiting broad spectrum antimicrobial use in the community that might be employed, and to think about it, and the availability of patient information leaflets to GPs and community pharmacists for future use. So really, there is enough room to improve antibiotic care by GP pharmacist collaboration. And absolutely, we need to think the system approach and the systems thinking that are keys to better understand this collaborative AMS implementation practice. And we need to sort it out some professional and attitudinal issues that need to be resolved. And what we told before, ID physicians and AMS pharmacists should delegate their AMS experience at GP and community pharmacy level to make a difference. And it's really high time to incorporate AMS component into the care models, where pharmacists are co-located in general practice, or the pharmacist doing home medicine review. So we need to think about it. So that's it. Thank you so much.
Sajal, we'll invite any questions to Sajal.